our Institute of Personalized Cancer Therapy program is a very sort of robust effort at trying to do a better job at connecting biomarkers to therapeutic decision making. So we are interested in both discovery as well as implementation of biomarkers for clinical utility. And one of the early aspects that we wanted to embark on is trying to figure out how we can better use genomics that has now come to be available in the clinic to better use for clinical treatment selection, and especially for ongoing clinical trials. As you know, for only a handful of diseases, there's actually a drug already approved for a specific genetic mutation. So, however, there's a large number of clinical trials now available where specific genetic mutation is being used as eligibility criteria for entry. And further, even in early phase 1 trials, we are interested in better matching patients, their molecular profile, to a drug that we think they will benefit more from. So there's a greater interest even for genomically non-selected trials to offer genomically matched therapies. Early in 2012, we initiated a protocol that we refer to as Clearinghouse, where we started offering genomic testing in the institution to really any patient who had advanced disease, where clinical trial selection was being considered early in their treatment course. So we offered genomic testing using a hotspot mutation panel, followed by then some exploratory research testing with targeted exome sequencing. And at this meeting, we were presenting the results of our first 2,000 patients enrolled. Everything's bigger in Texas, so we've enrolled a little over 5,000 patients to date. But we've been, tracking to see the utility of the genomic testing, the utilization overall for decision making, and now we're getting to a point where we're going to have a robust genomic database that we can link to clinical data to start making genotype-phenotype correlations, even for standard of care therapies. So this is a really exciting time, I think, in genomics. Yes, so we used a targeted hotspot panel, so that alone, of course, focuses on genes that we understand a little bit more about, and they're genes that are more actionable and that there are more trials for them. Using the panel we had about a 39.5% rate of identifying a potentially actionable mutation, or rather a mutation that's in a potentially actionable gene. That being said, of course, this number differs based on the tumor type being tested, as well as how we define actionability. However, we quickly noticed the drop-off really from identifying a patient that has a potential actionable alteration to getting to a point where we can identify a trial and that they would be eligible for. So this allowed us to do a critical review really of the challenges of personalized therapy and then devise sort of solutions for it. So not only was there not enough trials for especially rarer histologies, but also not enough recognition maybe even when the genomic test results came back. And the clear need for increased awareness of therapeutic implications of a genomic alteration when it is found. So in addition to sort of critically analyzing the data, we put forward a series of decision support tools within our institution. So we started offering a decision support service where the treating physicians that get a genomic report can really do an immediate consultation with getting insight from a research scientist about the meaning of a specific variant. And we all know, of course, that not all genes are the same, but of course not every mutation has the same functional impact. And more, I think, reports come in stating a patient has a mutation, but really not giving information about what is known about that mutation. Do we know that it affects the function of a mutation? And those are very critical things when we're thinking about enrolling a patient into a clinical trial. So we want to not only personalize that choice, but really make sure that the level of evidence for each individual gene's impact as well as each variant's impact is considered while deciding between other therapeutic options or a clinical trial, or if there's multiple alterations, allowing to use this information to prioritize the gene that's going to be targeted or optimal combinations. This is a very exciting time. I think we all realize that getting an increased portfolio of trials with, especially with the approach of basket trials was a very important first step. But I think we're all looking at rational combinations as our next step.